everyone, this video is part of the ERN Guard Heart educational videos for professionals. I am Anwar Baban, consultant cardiogeneticist from Bambino Gesù Children's Hospital and Research Institute in Rome, Italy. I am happy to share with you some aspects regarding genetic counseling. In this slide, we are going to share the main topics that we are going to discuss. What genetic counseling means a communication process between healthcare professionals trained in genetics and an individual or family affected by or at risk for a potential inherited disorder. According to the National Institute of Health, precision medicine is an emerging approach to disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. So what are the questions that we need to answer in genetic counseling? First of all, what is the cause of the disease? And why is it useful to patients to make specific diagnosis? And sometimes why is it useful for the whole family? And how can we make an early diagnosis? And how can we prevent potential complications? And what are the consequences or help that can be offered to families? And what is the recurrence risk of the disease? And what can we offer to families to control it? So why genetic counseling? Because it helps in transmitting knowledge of medical facts, explaining inheritance pattern and recurrence risk, discussing options to manage the disorder, and helping families in choosing most suitable option. Last but not least, offer them psychosocial support. So the main components are to identify, educate, and assist. Genetic counseling is the most immediate and practical service that genetics can render in medicine. It can be prospective, which allows identification of the disease, or it can be retrospective, where counseling is offered to individuals who are no carriers. Who does genetic counseling? This depends on local legislation and varies from one country to another. Mostly in inherited cardiac disorders, cardiologists who are expert in the field and who are trained in counseling are often the ones who give major counseling. Clinical geneticists are physicians who diagnose and manage families with genetic disorders. Genetic counselors typically receive bachelor's degree in biology, social science, or nursing, or related field, and they can go on to receive a specialized training, including master's degree in genetic counseling. And what does a clinical geneticist do? Review the reason for appointment, detailed clinical history taking, multi-generational pedigree is very important, review records and exams, information gathering and establishing or verifying a diagnosis. Sometimes a family comes to counseling thinking that they have a potential well-established genetic disorder, but when you check the records, you find, for example, a recurrence of ischemic heart disease, which is mostly related to hypercholesterolemia or other factors. So it's very important to check the records of the family members. Physical examination of available affected members, taking clinical photographs, especially when you have rare phenocopies of childhood onset cardiomyopathies, using computerized databases, genetic testing, establishing recurrence risk for known condition or empiric recurrence risk for known background. So the occurrence risk is the likelihood that a genetic disorder that's absent in a family can occur in an individual, where recurrence risk is the likelihood that a genetic trait or disorder present in one family can occur again in others. Another aspect that we need to know during genetic counseling are the major types of patterns of inheritance include monogenic and complex diseases. Monogenic diseases are caused by mutations or variants from a single gene, and they are usually rarer forms. They are the Mendelian diseases. They can be autosomal dominant, autosomal recessive, or X-linked diseases. The autosomal dominant diseases means that the gene in question is located on one of the numbered or non-sex chromosomes, and autosomal genes have two alleles, And by dominant, it means that it is enough to have a variant at a single allele to cause the disease, and each individual has the probability of 50% of it transmitting the mutated allele, but this does not always mean 50% of transmitting the disease. Since there are two main concepts in autosomal dominant diseases that are often seen in clinical practice. First is penetrance. Penetrance, it refers to the proportion of people who are genotype positive, so they carry the mutation, but still they are phenotype negative. It means that they do not show the disease. This is called a disease with incomplete or reduced penetrance. Sometimes it can be age-related. Expressivity, it means that it is the degree to which a phenotype is expressed by individuals having a particular genotype. So often it is variable in severity as a grayscale at inter- and intrafamilial level. Autosomal dominant inheritance pattern represents the majority of the genes causing inherited cardiac diseases such as cardiomyopathies, for example, the sarcomeric disorders, or arrhythmias such as the channelopathies. Autosomal recessive disorder means that the variant or mutation must be present in both alleles in order for the disease or trait to develop. Autosomal recessive diseases can be due to homozygous mutation or compound heterozygous mutation. And when you have homozygous mutation, usually there is two identical variants in both alleles at the particular gene. And it is often seen when we have consanguineous family, while compound heterozygous occurs when each parent donates different variant or mutation within the same gene, so the final product will always result in absence of normally functioning allele on both sides. In inherited cardiac diseases, it is rarer to find this pattern, though it exists, as in CPVT related to Cas2 mutation or in Yarble-Lange-Nielsen syndrome. X-linked is a trait where a gene is located on X chromosome. A carrier mother has the probability to have half of her sons to be affected and half of her daughters to be carriers as herself. Affected males often show an early onset of the disease. Females might have the risk to show the disease at a later stage in a more subtle way. This is mainly due to lionization process. In inherited cardiac diseases, the most frequently reported examples are Duchenne muscular dystrophy and Barth syndrome. Another pattern is complex diseases, which can be caused by the interaction of two or more genes with environmental factors. The genome-environment interaction is very often found in different cardiac diseases. Sometimes you have a more way for the genetic background, while in other conditions the environmental burden is more important. The third part of this presentation includes the factors that can influence genetic counseling. There are several factors that can influence genetic counseling. They include both psychosocial aspects and clinical aspects. It can be due to psychological and emotional burdens, and families may experience guilt and shame after the diagnosis of a genetic condition in a family member. These can be realistic guilt feeling, or they can be unrealistic guilt feeling. By realistic guilt feeling, for example, when an affected Noonan syndrome mother, she chooses not to have prenatal diagnosis and delivers an infant with Noonan syndrome. Unrealistic guilt feeling are seen when the individual feels response to a failure to reach certain goals and standards. Shame may be masked by denial, relabeling the losses as gains, or by finding fault with others. The counselor may become a figure of help or influence, especially early in the process of diagnosis, and sometimes it is of value to state that a particular condition is not their fault, and later the proband may remember this reassurance with comfort. It might be of help of directly addressing feelings and normalizing them by comparing the family positively to others in a similar situation. Sometimes it's important to limit the sense of responsibility for relatives' problem, which can be reframed as it is normal to feel responsible and to worry and care about your family members without placing blame for the problem. Another issue that is often need to be discussed with the relatives, especially parents of affected children, is to help them to define which aspect of their child's condition they can control and which aspect that they cannot control. This often gives them a way to feel more positive. Another aspect is that society is not homogeneous. There is a variety of ethnic backgrounds, socioeconomic status, and this will limit access to medical services and the perception of the information. So it is fundamental that the family needs support for its decision and full disclosure of options, but not a paternalistic counseling. Another factor that limits genetic counseling is genetic heterogeneity. So a single disorder can be caused by different genes, and a single gene can cause different disorders. Another factor is that we have a limited detection rate for the genetic tests in inherited cardiac diseases. For example, we know in long QT we can arrive up to 60 or 70% of detection rate, where it is very low in short QT syndrome or in Brugada. Sporadic cases common in inherited cardiac diseases, and in that case the pedigree will be unhelpful and the counselor must depend on an accurate diagnosis. And these conditions, the molecular methods, the genetic tests can help to identify the background and potential recurrence risk for the disease, or for the family, sorry. For example, this is in Barr syndrome in an infant male with cardiomyopathy, or is it just an isolated case of post-myocarditis? And by here we arrive to phenocopies that can mimic genetic disorders. Again, as we have said, dilated cardiomyopathy can be caused by genetic or by environmental factors, which are unlikely to recur, and the prognosis is completely different. Another factor that can influence genetic counseling is non-paternity or questioned paternity. And in the next few slides, we're going just to explain some basic aspects regarding genetic testing. Genetic testing helps in identifying individuals with a genetic disease or a genetic predisposition to a disease, or at increased risk of having children with a serious genetic disease. So it's very important to be careful with the terms that get used. It's not about getting normal or abnormal people. And in the clinical setting for next generation sequencing workflow, we always start by pre-test counseling, getting the informed consent, sampling, prescription, sequencing, alignment and variant calling, annotation, interpretation and variant classification. And by here we have the 5 category of the American College of Medical Genetics, the reports, and the post-counseling, We always bring all these factors during pre-test counseling, and we tell the family the possibilities for genetic testing by telling them that we can see up to, depending of course of the disease. For example, in this example we have a family with long QT. We tell them we'll do the panel, we'll find around 60% of positivity. So if we have negative results, either you don't have genetic background or the genetic background lies in the dark zone. And then the other possibility is that we have a variant identification, and for each variant they must lie in one of 5 classes. Class 1 and 2, benign, unlikely benign. They are usually not reported in the medical report, in the final report. Class 4 and 5, likely pathogenic or pathogenic. They predispose or disease causing, as I have said. Always remember reduced penetrance and variable expressivity. And class 3, these are the variants of unknown significance or the genetic purgatory. And so on, we go on with pre-test counseling, post-test counseling. So we need the integration between clinical and scientific data, phenotype, inheritance pattern, silico analysis, references, and databases. So why follow up in genetic counseling? To increase understanding, because sometimes in the first communication process, there's anxiety, grief, and fear that might interfere with the process of information exchange. Sometimes a phone call or brochures or introduction of support group can be of great help. Moreover, in the growing setting of the NGS results with variants of unknown significance, we need to do follow-up visits since certain variants can be reclassified, and in that case, we need to re-evaluate the interpretation of genomic variants. So in conclusions, as we gain further insight, geneticists and genetic counselors will need to be more and more familiar with the omics, including genomics and down to metabolomics, regardless of whether they specialize or become a generalist. In the process of genetic counseling, the patient and families are informed and encouraged to choose the best course for themselves in light of occurrence and recurrence risk, the perceived burden, for example, psychological, social, economic, and the relation to their ethical standards. Thank you for your attention.